കൃപയ്ക്കായി നന്ദി. Every Thursday is a special Thursday for us. അതുപോലെ തന്നെ ഇന്ന് ഞങ്ങൾ കേൾക്കുവാൻ പോകുന്ന കാര്യങ്ങൾ അത് ഞങ്ങൾക്കും മറ്റുള്ളവർക്കും ഹോസ്പിറ്റലിനും വരും തലമുറയ്ക്കുമൊക്കെ അനുഗ്രഹമാക്കി തീർക്കുന്നത് പ്രാർത്ഥിക്കുന്നു. പ്രത്യേകിച്ച് ഡോക്ടർ മനോയെ അവിടുത്തെ കരങ്ങളിലേക്ക് ഞങ്ങൾ ഏൽപ്പിക്കുന്നു. അദ്ദേഹം ഞങ്ങളോട് സംസാരിക്കുവാൻ പോകുന്ന കാര്യങ്ങൾ ശ്രദ്ധ വെച്ച് കേൾക്കുവാനും അത് ഞങ്ങൾക്കൊക്കെ ഒരു അനുഗ്രഹമായി തീരുവാനും ഒരു പുതിയ അറിവായി തീരുവാനും ദൈവം സഹായിക്കണമേ. വന്ന് ചേർന്നവരെയും ഇനി വരാൻ ആഗ്രഹിക്കുന്നവരെയും ഒക്കെ ഒരുമിച്ച് ഞങ്ങളെ അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥനയും യാചനയും കേട്ടതിനായി സ്തോത്രം. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
The slides are not moving, I think. Yeah. So once again, good morning everyone, especially to those who have just walked in. I'm going to use this first few minutes to introduce Dr. Mano, who many of you already know, but some of you have not met. Dr. Mano has been with the Believers family for many years now. He worked initially with us in the Department of Surgery and thereafter went for his training in MCH Endocrine Surgery at the Madras Medical College. And it is interesting, one small vignette is that actually he had got admission for MCH Endocrine Surgery in the All India Institute of Medical Sciences in Delhi. But when he did his research and saw how the work is, he preferred to let it pass, stayed on one more year, prepared, and he got into the Madras Medical College, where the variety of patients they operate is definitely far better. And it is a joy for us to welcome him back a few months ago to work with us. And it's a joy for us in the team of endocrinology to work closely with the Department of Endocrine Surgery to handle many cases which need expertise and finesse while they are operating. So this morning, actually, I'm going to set the ball rolling for Mano to do the bulk, 95% of the presentation he's going to do, but I'm going to take the first few minutes to present a patient. Why have we called this presentation the Hidden Hormone Havoc? Is because this particular diagnosis, primary hyperparathyroidism, is often missed, and I've seen so many cases in the last 8 to 9 years while working in Believers where diagnosis has been missed by various departments because these patients don't tell they have primary hyperpara and land up. They land up sometimes in a gastroenterology OP with constipation. They may land up with the urology OP with recurrent stones. They may land up in the psychiatry OP with abnormal behavior. I will tell you a story of a priest who lives near Kayangulam. His wife was behaving difficult. She was very difficult to manage. She was getting recurrent stones. Her behavioral problems were affecting him. She was on psychiatric medication. 4 times she went to a psychiatrist near Kayangulam. And she had stones blasted, removed, lithotripsy done, cured. Next time again the stone is recurring. But sadly, nobody thought of doing a calcium. And when they was brought to us, it was a very straightforward case of hypercalcemia, which led to due to primary hyperparathyroidism. She was diagnosed, and Dr. George Thomas in ENT did the surgery. This is about 7-8 years ago, and she improved dramatically her behavioral issues. The priest was struggling to balancing his church work and managing his wife, and so many issues and so much of expenditure had happened in her care. It was a case of a patient with primary hyperpara who was missed for many years. It was so gratifying to see that family restored because the diagnosis was picked up. But albeit, I wish a urologist had done a calcium much earlier. And that is one of the intentions of this PACE project, which we are going to launch at the end of the presentation. Manu, I told Manu I'll present the first patient because I'll never forget this lady. This lady, I'll call her S. I'm not revealing her name. She's a 29-year-old young lady who works in Dubai. She came to us with pain on the right calcaneal area, and she didn't come to me. She came to our orthopedician about 2 years ago, and she was given analgesics, and she was told to have Achilles tendinitis. Her blood routines and calcium apparently were done elsewhere, and so the orthopedician was very kind. He didn't repeat any of the tests, and he said, let's do an ultrasound, and the ultrasound showed tendinitis, and she was asymptomatic. Then she started developing pain again over the Achilles tendon, and he came back. But because the doctor in the orthopedics was so kind, she came back to him a second time. And this time, he said, let's do an ultrasound. Ultrasound showed tendinitis. Then she was not happy. It's not getting better. She went to Ayurveda. And then, next time, she came again after a few months with swelling over the right calcaneum. This time, the thought of the orthopedic team was to give her antibiotics. And she got better. That's the thing. No? Maybe the rest would have done better. Maybe because of the pain, she couldn't walk. And then she was treated conservatively and she got relieved. Then she went back to Sharjah and continued working, and again her pain recurred. And X-ray and MRI done in Sharjah showed there was a small cystic lesion in the calcaneum. And then this is the X-ray. It's not very clear here, the cystic lesion. Maybe that in the calcaneum there's a small cystic lesion, but it's not very obvious. So they did an MRI. And this is the MRI of the right ankle joint. It showed that there was a well-defined multiloculated expansile cystic lesion in the anterior half of the calcaneum with fluid levels measuring 3.83 to 3.7 mm. It's probably an aneurysmal bone cyst. She was posted in our theater. We got a bone excision done by our orthopedic team. Biopsy showed a right calcaneal lesion, giant cell rich lesion favoring a GCT with aneurysmal bone cyst-like areas. So this was the diagnosis. So we thought the problem was solved. Of course, she had not come to our team yet. She was still under orthopedics. This is the 5th visit to orthopedics team here. And then this was removed and they thought it's okay. She went home, came back again after a month saying, still I'm having severe pain on my heel and over the rest of the body. So our orthopedic surgeon was very worried here. And he sent her to Parimala Hospital for a bone scan, because sometimes these GCTs may not be benign. It may be malignant GCTs. That is the thinking process which he sent. And in Parimala Hospital, they did this scan and they said, this picture is not looking like GCT malignancy. This looks like metabolic bone disease. And the Parimala nuclear medicine physician gets the credit for the diagnosis. He ordered a calcium in Parimala when she went there for a checkup. The calcium came back as 13.5. And then he referred, Parimala physician and endocrine team, we are good friends. We often keep referring patients. So he sent her to me saying, sir, this patient's calcium is very high. But the patient was faithful. She went back to the orthopedic surgeon because he was her primary doctor, because he was so kind to her. That's what I want to say in the patient first movement here. To say that if you have a good relationship, the patient will just stick to you. Came back, and then the orthopedic surgeon sent her to me, and we found this. See the reports. This is the report which misled our orthopedic team outside. She had done a calcium in another lab outside. And remember, calcium tests are notorious for going off. This is 9.2, and perhaps this is why our orthopedician didn't repeat a calcium. The Parimala doctor repeated it, it was 13. The PTH was done only after that, 873. So whenever you have a high calcium and a high PTH, the diagnosis is a no-brainer. It's primary hyperparathyroidism. Phosphorus was extremely low. Vitamin D, she was replete. And the believers, our reports, within 3 days, we repeated it here, confirmed the diagnosis of primary hyperparathyroidism. And I must appreciate this lady's faithfulness to keep coming to us. Anyway, so for us, then it's a no-brainer. The diagnosis is clinched. It's high calcium, high PTH, normal renal functions, low phosphorus. The diagnosis is primary hyperparathyroidism. So then what happened? We went ahead and did an ultrasound. An ultrasound showed a nice 2.7 centimeter lesion, medial to the left common carotid to the left lobe. So there is a parathyroid adenoma. Then I had to send her back to Parimala this time, and they said there is a very clear sesame B scan showing an uptake. So it is a little bit of a circuitous route this lady had to go through, right? That's what I was thinking. So that's why we felt it's important to raise awareness about parathyroid disease, and Mano is going to explain what we did. We did a bone density which showed severe osteoporosis in the spine. Remember, she's only 29-year-old, no? Yeah, and especially over the forearm, that is in the cortical bone, the involvement is very severe. Can you see the femur neck? -7. So her bones had really become very thin. This is a parathyroid imaging done in Parimala, and that led to the confirmation of the diagnosis. The delayed image you can see in the third image on the bottom shows that even after they gave sesame B, the chief cells of the parathyroid hold on to the sesame B. They don't release it, so you can see the uptake there. And this is Dr. Anish, who did the surgery, and she did well. So she underwent a left superior parathyroidectomy almost 8 to 9 months after the initial presentation to our hospital, right? A story which reveals why we need to think a little bit broadly. And for her, she went on. Now she comes every year to see me. I'm so happy. She just came 2 months ago. Of course, because of that, she had PTH levels normalized. She had hungry bone syndrome after the surgery, and then she was treated, and she's doing well. So I thought this case will set the stage for the discussion today and what Dr. Mano has planned to do, and we discussed it. He will present 5 or 6 interesting patients, short cases. We won't delve too much into the pathophysiology, and then he will talk about the PACE project, and the story all begins with the Indian rhinoceros. Okay, so over to you, Mano.
Hi, a very good morning to all. Let me thank the organizers of Quest for giving me this opportunity today. So before going into the cases, let me start with how it all started. The parathyroid glands were first identified in an Indian rhinoceros in London Zoo by Sir Richard Owens. He was an anatomy professor there. So later, it was in 1850. Later in 1887, the parathyroid glands were identified in humans by Ivor Sandstrom, and he has published it in his monogram, Glandulae Parathyroideae. So, and the first parathyroidectomy was done by Dr. Felix Mandl in Vienna in a patient with recurrent bony symptoms and osteoitis fibrosa cystica in 1925. The first surgery was bilateral neck exploration, and that patient developed recurrent hypercalcemia later. So this is a story of Sea Captain Charles Martel. He was a captain in US Marine. He was 6 foot tall at the age of 22, and eventually he lost 7 inches of his height when he was 29. And he was, because of severe bone pain, he was diagnosed with primary hyperparathyroidism, and due to recurrent vertebral bone fractures, he lost his height. So that how bad can hyperparathyroidism present? And the surgeons couldn't diagnose it initially. So he underwent 7 surgeries, and after the 7th surgery, he was cured. The interesting fact was that the surgeons couldn't diagnose, so he himself went to Harvard Medical School library. He referred all the variations of parathyroid gland, and he himself suggested the surgeons to explore his mediastinum. And finally, what they found was he had a 3 into 3 centimeter anterior mediastinal parathyroid adenoma. So it was an ectopic gland which was missed. That's why he had a recurrent onset of primary hyperparathyroidism. So why PHPT deserves our attention? So it's mostly underdiagnosed disease. It's not a very rare entity, and it's a third most common endocrine disorder after diabetes and thyroid disease. And because it has protein clinical manifestation, it can present to any department it has a variety of symptoms. And it's often missed because the patient suffers years before the diagnosis. And if it's untreated, the patient can have a morbid life. It affects the quality of life, really. And another interesting fact is the geographic disparity in the clinical presentation of primary hyperpara. So if you look at data from the West, nearly 75 to 80% of the patients are in the asymptomatic spectrum because they have a routine screening for calcium, which was initiated in 1980s to 90s itself. So the main spectrum is asymptomatic disease. We hardly find any symptomatic cases there. Whereas in India, still more than 90% of patients are symptomatic. The reason being, one is the awareness gap. Second is the prevalence of vitamin D deficiency in the Indian population, which make them more symptomatic. So in other areas, there is a transition, like in Japan and China. So there's a stark difference between the presentation in the West and in the Indian population. So in prevalence in India is around 0.5 to 1%, and most common in women, with a peak incidence between 40 to 60 years. And as I said, more than 90% present with symptomatic disease. So in the last 2 decades in India also, we have seen a rise in the asymptomatic disease. From 2001 to 2010, it was around 3%. Now asymptomatic spectrum in India is around 14%. The main pathophysiology behind this is the reduced parathyroid calcium sensing receptor expression, so which is due to the epigenetic alteration in the promoter region, and the non-risk factors like previous neck radiation and even long-term use of lithium can lead to hyperparathyroidism. So as you all know, the PTH has a crucial role in calcium homeostasis. It maintains the calcium levels by increasing bone resorption, increase reabsorption from the kidney, and increasing absorption from the gut by stimulating vitamin D synthesis. So PHPD can be sporadic and or familial. So 90% is sporadic disease, what we see. Familial is very rare, which is associated with syndromes like MEN1, 2A, or MEN4, or familial isolated hyperparathyroidism, or it can present as neonatal severe hyperparathyroidism. We have seen a few cases like that. So the clinical phenotypes of PHPD include symptomatic PHPD, asymptomatic, and normocalcemic PHPD. Majority is symptomatic in our spectrum. Asymptomatic PHPD is usually picked up during the screening protocol, and they might or might not have a target organ involvement. Normocalcemic PHPD, it's very rare, even 0.5 to 3%, where they present with normal calcium levels, but the PTH will be raised. So they present with the classical pentad, as you all know, of stones, bones, groans, psychic moans, and fatigue overtones. We have been hearing it since medical school. So this is data from the Indian PHPD registry. So in India, the most common symptom belongs to the musculoskeletal category, where nearly 40 to 50% of patients present with bony symptoms, followed by renal stone disease with around 25 to 40% of the patients. And these are the percentage of other symptoms which it can present with. And this is the largest series presented till date from India, and mainly the data is from South Indian population. When we looked at the clinical profile data of our people in the South Indian population, generalized weakness along with musculoskeletal symptoms was the most common presentation. And it's a vague symptom. Generalized weakness any patient can have. So it's very difficult to diagnose it. So that was the most common symptom, followed by neuropsychiatric symptoms and recurrent renal stones. So musculoskeletal symptoms includes bony pain, weakness. They can present with pathological fractures and fragility fractures. So we can see this is a skeletal X-ray showing the brown tumor and subperiosteal resorption, and they have the clinical picture of osteopenia, or osteoporosis with the classical salt and pepper skull. This is what we see. Renal manifestations include more of nephrolithiasis more than nephrocalcinosis, and this is the second most common cause of urinary calcium stone, which account for 3% of urinary stones. And calcium phosphate stones are more common than calcium oxalate stones. And its stone formation is almost always recurrent. So unless we pick up the disease, the patient will keep coming back to you with recurrent renal stones. So it can also manifest as GI symptoms like peptic ulcer disease, cholelithiasis, pancreatitis, constipation, anorexia, nausea, and vomiting. It can also present with neuropsychiatric symptoms and end up with psychiatric department like anxiety, depression, memory loss, and all these symptoms can be seen in PHPD cases. So the symptoms vary with the calcium levels. Like with calcium level 16 to 19, you may have altered consciousness, paranoid ideations, hallucinations, etc. Other non-classical manifestations include cardiovascular disease, and hypertension is seen in 30% of these patients, and they can have left ventricular hypertrophy and diastolic dysfunction also. They can even have diabetes, hypertriglyceridemia, hyperuricemia, and chondrocalcinosis. So how do you evaluate these patients? So to start with, we have to biochemically confirm that this is primary hyperparathyroidism. Then only you will go to localize the disease with imaging. So how do you confirm it? So the biochemical panel includes serum corrected calcium for albumin, and phosphorus, intact PTH, vitamin D, serum alkaline phosphatase, serum creatinine, uric acid, and a calcium creatinine clearance ratio, which is of more than 0.01 is suggestive of PHPD. So the fifth international workshop have given the definition of hypercalcemic PHPD. So there should be the corrected calcium should be elevated or adjust in the presence of an elevated or inappropriately normal intact PTH. So that also comes under the hypercalcemic PHPD on 2 occasions at least 2 weeks apart. Whereas in normocalcemic PHPT, the calcium will be normal, but the PTH will be raised. And before diagnosing it, you need to check it twice in a 3 to 6 months gap. Then only, and we have to correct all the underlying causes of secondary hyperpara, because sometimes vitamin D deficiency can present with elevated PTH. So you can't really term it as PHPT. So you need to correct the underlying vitamin D deficiency, then check the PTH. So you have to diagnose it in 3 to 6 months time. So this is a clinical picture of PHPT, where the parathyroid hormone will be raised or inappropriately normal, calcium will be raised or normal, and phosphorus will be decreased. So that's how you compare with secondary hyperpara, where the phosphate levels are high and the calcium will be normal or low on the lower side. So next, once we confirm the diagnosis, we go for imaging. Before localization, imaging includes the 3-side DEXA scan we have to take. That's a lumbar spine, hip, and distal 1/3 of the radius. Or you can perform a high-resolution peripheral quantitative CT. So 3-side DEXA scan will give us a T-score. So a T-score less than -2.5 is suggestive of osteoporosis spectrum. So that is highly suggestive of PHPT. And vertebral fracture assessment we can do a trabecular bone scoring, and USG KUB or a C2 KUB to look for any renal involvement. Genetic evaluation is indicated in patients presenting with less than 30 years of age with PHPT, and with patients with a multiglandular disease by history or imaging, or the patients having a family history of hypercalcemia or a syndromic disease. So next we go to localization. So we have confirmed the diagnosis, now we go for localization. Localization, it's very important because the anatomical variation of the parathyroid glands, it's really important. You need to know about it as a surgeon. So 80% of the people have 4 parathyroid glands, 13% have supernumerary glands, and 5% of patients have less than 4 glands. So the superior parathyroid glands, they are almost always constant. 80% will lie within 1 centimeter at the intersection of inferior thyroid artery and the rectal nerve. Whereas inferior parathyroid glands, as you see, they can be anywhere, right? Because it has a long migratory path during the embryological development. So it can be as high at the level of hyoid bone within the carotid sheath, or it can even be seen in the anterior mediastinum. So inferior parathyroid are the most common cause for the missed parathyroid adenomas or the ectopic adenomas. So thorough anatomical knowledge is really required. So localization helps in telling us where exactly is the culprit gland. But one thing is, there are certain limitations with localization, like ultrasound and the sestamibi is a basic localization which we do. And if the ultrasound and the sestamibi scan locates a gland to one location, that means it's a concordant finding, then we can go ahead with surgery. If the finding is not concordant or discordant, that means ultrasound neck might or might not identify a lesion, but in sestamibi it identifies at a different site, then what we do is we need to go for a next line of investigation, that is 4D CT scan. So 4D CT scan is more sensitive than ultrasound and sestamibi, and ultrasound and sestamibi has a limitation mainly in the multiglandular disease and smaller glands. That's when we depend on 4D CT, which is more sensitive. And the newer investigation modality is F18 fluorocholine PET CT, which is a bit more expensive, but sensitivity is almost in the range of 4D CT scan. So when is surgery indicated? So any patients diagnosed with PHPT, and if they have any of this following, if the serum calcium is more than 1 milligram, or if they have skeletal involvement or renal involvement, then we suggest surgery. This is applicable even to the asymptomatic hyperparathyroidism patient. So if they meet any of these 3 criteria, then we have to go ahead with surgery, because the patient will progress. Age less than 50 years is suggestive of progressive disease, so that's when we suggest surgery for them. Surgical options include bilateral neck exploration. That was the conventional one. It's been followed for many years, and right now it's indicated only in multiglandular disease and in syndromic cases. And what we do, and if there is a concordant finding, we go for a minimal invasive or a focused parathyroidectomy. That means we'll go for only that particular lesion. If ultrasound and sestamibi shows a particular lesion in any of the 4 glands, or if it's in the mediastinum, we go focused only for that lesion. That by less morbid condition, we can discharge the patient early and small scar. So that's the advantage of preoperative localization. So this is a bilateral neck exploration scar. incision, it will be because we need to explore both sides. If the imaging findings are not concordant or discordant, then we have to look at all the 4 glands because we are not sure which is the culprit gland. So we have to explore both sides. That is called bilateral neck exploration. And if we are going for one gland, it's focused parathyroidectomy. So coming to the second case, this 36-year-old female presented to the ER with nausea, vomiting, constipation, and tiredness. She also had severe bone pain, and she also gave history of, the bystanders gave the history of depression, anxiety, and she was admitted under nephro. And on evaluation, she was found to have a calcium of 19.24. And she was managed initially for the hypercalcemia, and she was given IV fluids, denosumab, calcitonin, and tapsinacalcit, and the calcium level was brought down to 12. And the biochemical diagnosis of PHPT was confirmed. Then we went ahead with an ultrasound neck for the localization. Ultrasound neck showed a right inferior parathyroid lesion of 3 cross 1.9 centimeter. Sestemi B scan was not concordant, so we went ahead and did a 4D CT. 4D CT is nothing but the 4D is the 4th dimension is the time. So because the parathyroid glands, they have rapid uptake during the arterial phase and early washout in the venous phase. But whereas the thyroid gland, they won't have early washout. So that's how we differentiate between thyroid and parathyroid. So that's the 4th dimension in CT. That's a 4D CT scan, which is more sensitive. So 4D CT also localize a lesion to the same right inferior parathyroid gland. So it's a concordant finding. So we went ahead with unilateral neck exploration because there was a loss of fat plane between the parathyroid and the thyroid. So we had a plan of right hemithyroidectomy also in mind. So underwent a right inferior parathyroidectomy. So this is the intra picture. You can see the thyroid gland here, and this is a parathyroid lesion. This was a cystic parathyroid adenoma, which is not a very common finding, so it's a rare entity. So, and we use intraop adjuncts like NIRAF and ICG to diagnose it intraoperatively also, to confirm the location. I'll be talking about it later. So the specimen, even the specimen had the autofluorescence property. So how do we confirm that we have identified the correct parathyroid? So there is another intraoperative adjunct called IOPTH. It's called intraoperative PTH. So the parathyroid hormone, the half-life time is 2 to 4 minutes. So what we do is, so once the specimen is excised, the PTH level drops within 5 to 10 minutes. So we can send a 10 minutes post-excision PTH sample. So it will drop. If it drops more than 50%, it is suggestive of cure. That means you have cured the patient, you have identified the correct culprit gland, so now you can end your surgery. So this patient had the intraoperative PTH fall of 89%, it was 60.3, so it was suggestive of complete removal. And the biopsy came as a parathyroid adenoma, and her follow-up calcium is normal. The third case was a 48-year-old female with recurrent renal stones, and she had a bilateral non-obstructive renal calculi. Her calcium was 11.7 and the PTH of 127. On imaging, showed a left inferior parathyroid tumor in the ultrasound, and she had a bilateral non-obstructive renal calculi also. Her DEXA scan showed a distal radius T-score of minus 3.1, which is suggestive of osteoporosis, and intraoperatively there was a left inferior parathyroid adenoma. So there was 85% fall in the IOPTH, which was suggestive of complete removal of the lesion, and the biopsy came as parathyroid adenoma. This is another female, 62-year-old, who presented with abdominal pain, distension, vomiting, and diagnosed to have acute pancreatitis. And on evaluation, her calcium was 12.4 with a PTH of 514.9. So initially, she was managed conservatively with zoledronic acid. Later, once she was stabilized, her all symptoms resolved. 1 month later, she was operated. So she had a right superior parathyroid tumor, and on system AB scan, which was concordant finding. So she also had, on imaging, the CT abdomen was taken for pancreatitis. At the same time, she had it has shown as a renal calculus was there. So she had a right superior parathyroid adenoma, which was removed. And this patient, at 10 minutes, there was only 40.5% fall. So that is not in the sufficient range. There is no 50% fall. So in those cases, we have to send another sample at 20 minutes, so which showed 88.8% fall, which was suggestive of the exact removal of the culprit gland. So another case which was operated elsewhere in 2022 for primary hyperpara, but she had persistent symptoms, and on evaluation she had a persistent hyperparathyroidism. So on her calcium was 12.4, and the phosphorus was low, and the PTH was also in the higher range. She had generalized weakness and bony pain. This was a main complaint. So the DEXA showed a T-score of -3.1 and the AP spine region. So ultrasound was not very sure. We were not sure of the lesion, so it was not a typical lesion. So we went ahead with the 4D CT, which showed a right superior parathyroid tumor. And we went ahead with focused parathyroidectomy, and the culprit gland was the right superior parathyroid with a 94.6% fall of IUPTH at 10 minutes. And the biopsy came as parathyroid adenoma. So the most common cause of failure is either an undiagnosed adenoma. Maybe in this case, they would have sent, maybe could be a lymph node or thyroid nodule as parathyroid. That's why she was, that's why it was a failed exploration. So we need to have thorough anatomical knowledge where exactly is the parathyroid. Then only we can identify the gland and cure the patient. And the last case was a 72-year-old female who presented to the ER with slurring of speech, nausea, drowsiness, and she was admitted in ICU. And she also had AKI. On evaluation, her CT brain was normal, and on investigation, her calcium was 20. It was more than 20, and PTH was 4028. So she had all the neurological symptoms, and she was in crisis. So she was managed conservatively initially, and later, after 4 days, she was taken up for surgery after stabilization. She had a right superior parathyroid tumor with a DEXA score of -5.1, T-score of -5.1, and distal radius. So her X-ray showed osteoporosis and the classical salt and pepper skull. Her 10 minutes post-op, post-excision PTH was 97.5, which was a 97.6% fall. So, which is suggestive of complete removal of the parathyroid lesion. So the patient improved drastically from the very next day onwards. She was admitted and she got out of the hospital on the 10th day. She was admitted to ICU initially. So she improved drastically after the surgery. And the biopsy came as parathyroid adenoma, but she developed hungry bone syndrome, which is a sequelae to hypercalcemic crisis or patients with severe bone disease initially. So what are the surgical challenges? As I said, ectopic adenomas is one of the surgical challenge, and multiglandular disease and multigland hyperplasia, or it could be double adenoma. So if you remove only one adenoma and you come out, the patient still have persistent hyperpara. So you need to identify the disease. We need to correctly localize it. That's very important. And preoperative parathyroidectomy, again, because of the field scarring, we won't be that anatomical. The virgin anatomy is lost. So then you need to really find where exactly the parathyroid gland is. So outcomes after the surgery include 95% cure rate in the expert hands, and the patients will have symptomatic relief in terms of renal colic. The patient won't develop further stones, but the damage which has already happened to the kidney would stays. So he won't develop new stones, and 30% reduction is fracture risk, and bone mineral density improves 8% in first year, and it improves up to 15% in another 5 to 10 years. So a few words about the adjunction parathyroid surgery. So the adjunct what we use here is NIRAF, near infrared autofluorescence. So all the parathyroid glands has an innate autofluorescent property. So if we excite them in the near infrared light, it will re-emit another light which is captured in the camera. And that re-emitted light and that autofluorescence is 10 times stronger than the surrounding thyroid tissue, lymph node, all other tissues. So that is the property which we can use to identify the parathyroid glands. This can be used intraoperatively for thyroidectomy surgeries also to identify the parathyroid glands. This is the Ehrlich fluorescent imaging system which we use here. So this is the near infrared camera. So this is a case of with a right superior parathyroid adenoma as a patient. So we identify the gland by visual identification, and we confirmed it with NIRAF. So this is autofluorescent property. So this is how we see in the camera. So this is autofluorescence of the parathyroid gland. It gets lighted up, and it's 10 times stronger compared to this is a thyroid tissue, and this is a parathyroid. It's stronger than the surrounding tissues. So it's a specimen. Even the specimen has that autofluorescent property, so it won't be lost even after formalin fixation also. That is a fluorescent property of the parathyroid gland. So it is a highly sensitive investigation, modality with a 97%. And the adjunct is, another adjunct along with NIRAF is ICG. We can inject ICG dye, which also lights up the parathyroid gland. So this is a cystic parathyroid lesion, which I showed initially. So after giving 1.5 ml of ICG, within 20 seconds, the thyroid and the parathyroid gland gets lighted up. This is the same image under ICG with the NIRAF camera. So first the parathyroid gland gets lighted up, followed by thyroid. So in that way, we can confirm that this is the parathyroid lesion. So IOPTH, as I have already mentioned about it. So that with using IOPTH, you can increase the cure rates up to 98.3%. So what we follow here is a Miami criteria, where if there is a 50% fall at 10 minutes excision sample, that is suggestive of cure, and you can stop the surgery there. So that means you have identified the correct parathyroid gland. If there is no fall at 10 minutes, you can send a 20-minute sample. If there is no fall at 20 minutes also, that means your culprit gland is somewhere else, sitting somewhere else. You need to re-explore again. You need to explore the opposite side and look at all possible locations of the parathyroid. So that's how we use IOPTH as a guidance for surgery. And this is another new adjunct, the radio-guided parathyroidectomy, where we inject technetium-99 sesame B, and using the radioactive probe, you can identify the lesion. That's all about the cases. Now, a few words about Project PACE. PACE stands for Parathyroid Awareness, Collaboration, and Evaluation. This is a combined initiative from the Department of Endocrine Surgery and Endocrinology to create awareness among the clinicians about the disease, because it is really underdiagnosed in our situation. And it also aims at early detection of the disease, and we propose a simple screening program where we can check a serum corrected calcium at high-risk patients and patients presenting with any of these symptoms, so that you can detect this disease in an early stage. And we want to collaborate with other departments where this patient can present. And upon diagnosis, and referring the patient, we will do a structured workup algorithm for this patients to diagnose the disease. And our aim is to make this patient ready for surgery and cure them in the next 4 weeks. So that's our aim. And we are planning to start a parathyroid registry with hospital-wide PHPT patient database, and planning to conduct regular audits and looking at the outcomes and evaluating us. And also we aim to give education to the patients and give long-term structured follow-up plans for them. And we also would like to create awareness among the public also through the media and through IMA talks. And finally, we want to make BCMCH as a central referral hub for PHPT evaluation, surgery, and follow-up. So it's not a single department effort. It needs collaboration of various departments to which PHPT can present, including urology, orthopedics, internal medicine, rheumatology, geriatric medicine, gastroenterology, family medicine, psychiatry, radiology, nuclear medicine, and biochemistry. So the take-home message is, think of PHPT in your patients with these symptoms and check calcium when it's appropriate, and help us connect the dots by referring early. So what I would like to say is, I've met a few consultants in person. We'll be meeting everyone in the coming days to talk about this project. And PHPT is really an underdiagnosed disease. And together we can change the spectrum from the late complicated PHPT to an early curable PHPT. And I request all your support. Thank you.
Oh, thank you, Manu, for that excellent presentation. It was so eye-opening, no? In many ways, I think patients can come to any of the departments, right? with various symptoms, and it's unless we think of it, no, you can easily miss this particular condition. So before I open it out, I just want to say a conversation I had with the head of PGI Chandigarh recently in a conference, Dr. Sanjay Badada. He was telling me that he asked me a question. Do you know what is they have a registry of parathyroid disorders across the country. He collects data and he's got a privy to nearly 2,500 patients PHP. He asked me, what is the commonest reason these people die, he asked me. Anybody wants to guess in the crowd, except those in the endocrine department, endocrine surgery, are not allowed to answer. What do most patients of PH? We think that after we remove the parathyroid, patient gets better, end of the story, happy ending. No. We have to follow up these people. And when they followed up, you know what the commonest cause of death is? CKD, chronic kidney disease. Because many of them come to us very late. They've already had renal damage. It may be like an AKI part will get better once you correct the hyperpara. And even last week, I referred a patient, Dr. Gio, one gentleman who lives in Kuttur, next door, who came to us with florid hyperpara. We treated him, but his creatinine is now at 1.8. So regularly, Dr. Gio has to follow him up. So what I'm saying is we know that. So we have often lost the game when they come very late. So I think that's why the SPACE initiative is very important, that we pick up things early to prevent the ravages of this. And so we don't want our patients to develop renal failure and all. So anyway, next 10 minutes, Mano has finished dot on time. I told him not to exceed 8:50 and he's finished on time. We have 10 minutes for discussion, so nobody has to rush away. Any questions, thoughts from the surgeons and from the medicine? Yes, madam.
See, as far as the hyperparathyroidism is concerned, it is one of the most important challenges in as a radiologist. Patients came with all these symptoms, even the psychiatric problem. We will evaluate him or her. And the thing is, the one patient, the Philippine was discussing, she had a lytic bone lesion in calcaneum. So whenever you see lytic lesion in any of the bone, formerly we used to do the skeletal survey. So we should have done that. Skull, the typical pepper pot appearance. If bone erosions, we should have picked up. That is the importance of following up of the patients with the parathyroid disease or with the vague symptoms, especially females. നമ്മൾ എപ്പോഴും പറഞ്ഞു ഇവർ ഫങ്ഷണലാണ്, ഇവരെ നമുക്ക് വിട്ടേക്കാം, ആ ഒരു ആറ്റിറ്റ്യൂഡ് പാടില്ല. യൂഷ്വലി parathyroid adenomas and disease are more common among females. Well, recently we had a case, patient was 32 years old, 38-year-old young man, and we examined her during the package, then golden or silver package. Our postgraduate student examined him first, and he identified a cystic lesion in the kidney, which is he is supposed to it is connecting with the collecting system. So he brought the patient to me. When I examined, his renal medullas shows a different pattern. So usually the renal medulla that is a renal pyramids are hypoechoic, but instead that patient's renal medulla or pyramid shows hyperechogenicity. I asked everything, but he doesn't reveal the history of parathyroid surgery. After the questioning for 10 or 15 minutes that I had a surgery, because he may be not like to reveal that. After for 6 or 7, 1.5 years before surgery, he had a surgery, parathyroid was removed, but the calcium deposit in the renal pyramids are still persisting. Whether it will damage the kidney, how much time it will take to disappear the calcium from the renal pyramids? That is my question. That is the importance of following up the patients. So I express my sincere thanks to doctor for highlighting all this usually missed disease. Not a single parathyroid matram, it is affect our entire body. The most common cause of death is the renal disease, renal parenchymal disease. Thank you.
Thank you, madam. Any other questions? Yes, Dr. Shaul sir and then Dr. Jensi, both have lifted hands.
So one of the common practice is to give vitamin D and calcium from different specialties in different forms. So most of the patients are not aware they are getting the vitamin D and calcium, and ultimately they land up with hypercalcemia and hyperphosphatemia and low parathyroid level. And very often, sometimes rarely, because of the 1-alpha hydroxylase secondary to lymphoma and sarcoidosis, presented with hypercalcemia, hyperphosphatemia and low parathyroid. So any biochemical test to differentiate these things.
So whenever, sir, we have hypercalcemia, the most important investigation we use to differentiate, especially because of the rampant overuse of vitamin D treatment, is we do a PTH. So that's how we classify hypercalcemia as PTH dependent hypercalcemia and PTH independent. PTH dependent, the most important cause is primary hyperpara, where you have high calcium and high normal PTH. Whereas in PTH independent causes like vitamin D excess, lymphoma, and other conditions, particularly malignancies, you have PTH will be low or suppressed. So PTH is the single most important investigation to distinguish. I tell you one patient I remember many years ago in Vellore who was admitted with a calcium of 15. Those days we didn't have PTH. In fact, PTH, the test would take about 1 week for us to get the results. But the history we had missed, my boss picked it up on the rounds, was that this patient had been going with vague aches and pains to many general practitioners in North Arcot district. And everybody was giving arachital injections. An arachital injection is vitamin D 6 lakh units. He was getting it every week for 3 months. And he had gone into hypervitaminosis D. And based on that, we had started him on steroids, hydration, all the treatment, but he passed away, sitting in Vellore Hospital. So this is also a problem. Sometimes we know 90% of us are vitamin D deficient, but overuse of vitamin D, especially the injectable forms, can be lethal, as Sir mentioned rightly. Thank you. Jency.
Yeah, thank you, Mano, for that excellent presentation. One of the challenges which we face is many of our, we have few hyperparathyroidism cases under us. They have geriatric population with multiple comorbidities. So whenever we refer for surgery, hearing all the complications, they are just not getting the surgery done. So finally, they just go ahead with the sinacalcet and their own follow-up. One of the lady, she had to come back to the hospital twice or thrice with septic encephalopathy and seizures with hypercalcemia. But every time she was passed off as a high risk for surgery. So how do we tackle this part of the problem?
Yeah, I think I'm glad you raised that question, because this is precisely why Dr. Tom George and Dr. Ashwin need more referrals from interventional radiology. We had a lady like this, 80-year-old, children both in the US, who came to us with hypercalcemic crisis and got admitted under Arun in nephrology, if I'm not mistaken. She came with severe hypercalcemic encephalopathy. She was confirmed to have high calcium. She was operated already in Lakeshore once before, failed surgery for parathyroid. And then this time the surgery was necessary. And Dr. A.S. Matthew told, we will operate. Sir was very confident. Within 10 minutes, he will come in and out. That was a confidence Sir had, he will do the surgery. But patient family said, she's already had a failed parathyroid. I will not agree for a second surgery. And we knew that she needed it. She's 78-year-old, and she had already developed some Parkinsonian features, many problems, comorbidities, ASA grade 4, Dr. Ashu told us. So that's when we involved Tom in the case. Tom did a radiofrequency ablation. This lady is now cured of hyperparathyroidism. She's actually a lady who was almost bedbound, homebound, has now become independent, active. So we must offer radiofrequency ablation, costs less than 1 lakh rupees to do this procedure. So the family came from the US. Today she's coming regularly to us as a follow-up patient. In fact, a Parkinsonism has also settled down. We have taken off all the anti-psychiatric drugs she was on. She's doing so well. And actually, I did present this in the US Society of Endo, but I think I presented it once in the Quest many years ago, 2 years ago. So you must offer radiofrequency ablation. It's a non-invasive procedure for high-risk surgical patients. I'll share the details with you later. Anybody else? Any other questions? My surgical team, Dr. Rennie, Dr. Naik. Any of the physicians? Anybody else? Dr. Anish, any comments? He has done most of our parathyroid patients in the last few years.
Good morning, everyone. As Mano readily pointed out, it is a disease that we usually miss out. And not among doctors, even among surgeons also, many of them do not know about hypercalcemia, how to work up a parathyroid case, whether to go for a 4-gland exploration, how to find it out. And parathyroid also has an important anatomical structure that it is very close to the nerve. So people are again worried about the voice and everything. So we have to have a postmenopausal bone health checkup plan where all postmenopausal women are checked, their bone health is checked, calcium is checked. Like sodium, potassium, calcium also should be an important element. It is not that we should order for a calcium. Calcium should come to us. Now everyone is doing vitamin D, that is costing around 1,500 rupees. No one is doing calcium, which is costing around 70 rupees. So everyone is looking at vitamin D, they are having calcium and vitamin D tablets. So the symptoms are very vague. So we have had asymptomatic patients. in our society, the patient should have at least 5 or 6 renal stones, which is coming back after surgery or a broken bone, so that they have to come and meet us. So that scenario should change. So our initiative of awareness for parathyroid will, I hope that it changes that. So thank you.
Thank you. So we have almost come to the end. Just one carry-home message. We are planning to, Dr. Mano is doing a presentation in the Central Trameco Physicians Club next Friday. So if you can tell the others who have missed it, they can listen to this presentation in a slightly modified version. So hopefully he'll get a little bit of publicity. And he's doing 2 IMA presentations in the coming month as well, so that we spread the awareness of it. And that's the first thing I want to say. Second thing is we have 2 endocrine surgeons who are familiar with using NIRAF and ICG, all the newer techniques in confirming the parathyroid disease. So we have done more than 40 to 50 patients from the endocrine surgery team in the last couple of years. And so we hope that these numbers will rise. Usually the criteria for ordering a calcium is usually only the recurrent stones the urologists do. So we already convinced the urologists, even if it's a first stone, that may be the beginning of a recurrent stone, right? Can we do a calcium? They were only doing uric acid and creatinine. So Dr. Thompson sir and Dr. Nainan, we have had a meeting with Dr. Jibu as well. They said, with even the first stone, we'll do a calcium. It costs only 80 rupees. But sometimes I notice PTH is done first, but calcium is not there. That is also something which I often observe on consultations. I'm not saying the medical team, but very often it's missed out ordering a calcium. So I request you all to consider doing calcium when you have these vague symptoms. Sometimes it may be a bit. So thank you very much. If there's no other questions, I'd like to bring this presentation to a close, and I want to thank Mano. Shall we give him a round of applause? And we pray that all of you will cooperate in raising the awareness and diagnosing, and if you can refer patients to the endocrine surgery and endocrine, we'll be happy to help you in the evaluation. Thank you so much. Have a good day.